morning, everyone. We'll get started. Welcome to the evolution of reimbursement. My name is Carrie Nixon. I'm with Nixon Gwilt Law. We focus on serving healthcare innovators around the country, including digital health companies, life sciences and med tech companies, and providers who are doing something transformational. I am delighted to be moderating this panel today. I'm joined by Dr. Marion Couch, who is the Senior Vice President and Chief Medical Officer of Cambia Health Solutions. She is also the former Senior Medical Advisor at CMS and was there during the time of COVID. So she's going to have some really interesting things to say on that front. Cambia is focused on technology-enabled person-centered care in the Northwest, the Pacific Northwest. So thank you for traveling and joining us today. We're also joined by Greg Deavens, the CEO of Independence Blue Cross in the Northeast region of the US, based largely in Philadelphia and Hartford. So Greg is very familiar with value-based care and reimbursement. He deals with it every day, and we're looking forward to hearing what he has to say as well. So I want to take a moment to tee up our conversation today. The main question that we're going to be focusing on is, does policy hold innovation back? I think that is a really key question in this day and time. And specifically, we're going to be talking about reimbursement policy. Both of you are very focused in your current jobs on value-based care. And in my mind, by definition, that makes you all innovators. So, we have a deep rooted basis in fee-for-service in this country. We're trying to make the shift to value-based care, but some of those deep roots with the fee-for-service model can be difficult to make the transition and to overcome. And there's a lot of policy around fee-for-service that may constrain and sometimes may help our shift towards value-based care. Let's start off our conversation and talk a little bit about reimbursement policies, specifically around digital health. Marion, I was wondering if you could first feel free to tell us a little bit more about Cambia and your time at CMS, but then provide us with an example of a payment policy that actually facilitates innovation in digital health.
Thanks, Carrie. I think it's important to state that, like many payers, we at Cambia were very interested in digital health. But if you're a provider, what CMS did was very important in terms of the transformation and the wide implementation of digital health, telehealth. So when the pandemic hit, I happened to be in the office of the administrator, senior medical advisor. And I think if you ask the administrator, the person who was most vocal in the early days about we have to have digital telehealth, we have to have a way of rolling this out, was me. And that was because we had guardrails placed by Congress due to the potential cost, I suspect. But we only had virtual visits and e-check-ins. And they were only for established patients, and they were only for types of visits where the member had to go to the doctor's office. And by rolling out in a broad stroke, all these flexibilities, rolling back regulations, which was, I maintain, exactly the right thing to do. 80 more services, approximately 150 flexibilities were rolled out. That really helped transform the acceptance of digital health and telehealth. And so what you pay for is really important. And so for me, the small silver lining of this terrible pandemic may be that there's this unbelievable catalyst for innovation. And as we're rolling out all these flexibilities, new services, new range of providers that could participate during the public health emergency, our hope was that we would then figure out, coming out the other end, what was of value. In other words, a lot of high volume, low value telehealth visits will be important because it won't add anything. It'll just increase costs. So we hope that there'll be work done so that we can figure out where telehealth will end up being of value. So for me, the rolling back of the regulations, which are still ongoing during the public health emergency, are a great example of how we pay for things works. And payers like Cambia embraced it. We were thrilled. We were paying at parity, and now we have to figure out how we'll pay for that. But it's a great experiment And again, opening up and deregulating in that way, I think is really important to consider as we go forward.
Yeah, you raised a really interesting point, Marion, and that was mentioning at the beginning how telehealth reimbursement was very much constrained by law passed by Congress. And there are many people that I think don't realize that, right? It is an important point to make that we are, in my belief, much better served allowing CMS the flexibility to regulate and make policy around the changing landscape versus having some policy locked in by legislation that actually has to be changed by another passage of another law, which we know these days is actually a pretty difficult thing. So, while we have the flexibilities right now with respect to telehealth policies because of the emergency waivers, we all know that the moment those waivers go away, we're not certain what's going to happen with telehealth. And frankly, it's going to have to be addressed by legislation. So, I think the lesson there is legislate as broadly and as little as you can and let the people who are the policymakers at the administration level make sure they're making the right policies to implement those. So, Greg, let me turn to you. Can you give me an example around some reimbursement policies that you've noticed with respect specifically to digital health that have helped you out?
Well, Carrie, I appreciate the question. I think the point that was raised earlier about changes in government regulations and expectations is critical. And certainly that, I think, helped to really generate a level of interest among providers, and certainly there was a great interest among consumers. As it relates to reimbursement, I think the expectation that reimbursement rates for telemedicine visits be at parity with in-office visits was a real catalyst.
Yeah.
And it was frankly a necessity in the midst of a pandemic when people couldn't get out and get to their providers' offices the way that they did pre-pandemic. And so I think now that more consumers have experienced that, more providers have experienced that, they see the benefits that are being derived. I think now the question is, how do we maintain it for the long term? How do we make sure that reimbursement arrangements are appropriate for the long term and continue to incent that continued utilization? And I think there are just so many benefits that we've been able to derive from that change. And we look at the uptake that we saw in telemedicine visits. I think in 2019, before the pandemic, we had about 18,000 telemedicine claims for the whole year. And that went to 1.8 million in 2020. And so I don't think we'll sustain at that same rate going forward, but I do think there will be a continued use. And I think also, there'll be expanded services that can be provided through similar means going forward. But the reimbursement is going to be critical.
Yeah, you raised the parity issue, and I do think that's critical. What do you see as the potential impact if parity payment and parity for telehealth services is not sustained beyond the pandemic? If, for example, reimbursement for a telehealth visit is significantly less than what the in-office version would have been?
Well, I think, pre-pandemic, certainly reimbursement rates were a very small fraction of in-office visit reimbursement levels. I don't think we're going to go back to that. I think there should be some differential because, one, we've learned during this period of pandemic that the number of people that actually make an appointment and cancel it has gone down. So more people are actually proceeding with their appointment with their providers. They're not consuming the same level of services as they would when they go in person in terms of the office staff that's required to support it. So there certainly are some differences in costs that I think need to be recognized. But I think that the reimbursement rates probably need to be a little bit closer together than they were pre-pandemic. And that's certainly something that we're seeing and focused on.
Yeah. Marion, what do you think on the parity issue?
I think in the fee-for-service world, it's a little bit more difficult. For instance, behavioral health, telehealth visits. Oh my gosh, that's transform that area of healthcare. And I think a lot of us could argue that that should stay at parity. When you're in a value-based world, it's less of an issue because you're using it as a way to reach your patients.
Right.
And it's much less of an issue. I think the real sticking points will be if we remain firmly in the fee-for-service world. And I'm going to tell a story, and don't tell my mom, but the amount of time it took her to get online,
Yes.
to have a telehealth visit was not trivial, and she loves it. So, I understand, especially as a former surgeon, all the office expense when someone comes for a visit, but I think we're learning about what the expense is in technology and setting people up in time for telehealth. So again, I hope we come forward with evidence to help us figure out what that level of spend should be.
Yeah, now at Cambia, I know that you are very tech-enabled in general. But Greg, in your system, were you able to, how did you shift your thinking about telehealth and how quickly it was able to be implemented? Did you feel like you were behind the 8 ball because it hadn't been elevated as much as it could have been pre-pandemic?
Well, Carrie, I think you're mixing a little bit my day job and my other job. So I have the pleasure of serving as CEO of Independence. So certainly view it from the payer side, but I also am the chair of the board of Hartford Healthcare. So I see it from the provider side.
Yeah.
And I think that with respect to the health system side, they were really able to pivot and really get a lot of the providers in the system, particularly the employed physicians, to really embrace telemedicine very quickly. And as a system, they had the scale to allow them to invest the necessary resources to make that happen. But also, they recognized one of the challenges that I think was uncovered with the increased use of telemedicine was the fact that we still have communities in this country that don't have broadband access. And so for those communities, the health system really needed to think about different ways to reach them. And so in the case of Hartford Healthcare, they were able to put in place a fleet of mobile vehicles to go out and provide testing. And then ultimately, when vaccines became available vaccination services for their patients. But it's fortunate that they had used those kinds of mobile capabilities before, really focused around mammographies and other types of diagnostic procedures that certain communities were not availing themselves of at the same rate. And so I think it has been just a tremendous learning experience for the whole healthcare ecosystem.
Right.
And I think there are tremendous opportunities for us going forward. I guess the one other thing I would say that I think is a bit of a silver lining coming out of the pandemic is the whole area of remote monitoring. Mm-hmm. And so we saw a number of health systems really start to provide some remote monitoring services for some of their patients, particularly cardiac patients that needed to be monitored post-procedure. And if it was safe for them to do that at home, they could do that with some technology that enabled remote monitoring. And so we're really focused on that in a number of areas, focused on it for diabetics. So there are devices that allow you to measure the temperature of one's feet to determine whether or not there's a risk of an ulcer that could result in an amputation. So there's a lot of opportunity, I think, ahead in this space.
I've been delighted to see sort of the elevation of remote patient monitoring and increased utilization. I think that was a really underutilized opportunity previously. Yeah.
Carrie, as Greg was talking, it reminded me, we're very committed to improving health equity. And if you look at rural and underserved communities, the telehealth piece and remote patient monitoring is going to be huge. And so I'm hoping that we don't lose sight of that as we go forward.
Right.
It may not be perfect, but a remote consultation for someone living in a rural community may be a huge lifesaver. It moves up their time to treatment by weeks and weeks. So I hope we don't lose track of the fact that we now know ways of improving care and access to those communities.
Absolutely. So let's shift gears for a moment and take the flip side. Can you all think of a reimbursement policy in particular that has negatively impacted your ability to innovation in digital health?
I think, you talked about some of the waivers that were provided before. I think before the waivers, I think there were certainly some barriers, but again, I think in this period we've learned a lot. Those waivers have been critically important. And so, I would hope, as you suggested, Carrie, that going forward that, from a legislative standpoint and from a regulatory standpoint, there'll be more flexibility provided to CMS and to other bodies to make sure that we have the ability to continue to modify how we do business, how the payers and providers interact with one another, et cetera, so that we are able to take advantage of some of the technological advances that are coming very quickly at us. And I think having that flexibility built in to adapt the system quickly, I think is going to be critically important.
Yeah, I think that's exactly right. And you had mentioned remote patient monitoring earlier. I know that one thing that I hear a lot is that there is a requirement that you have 16 days of transmitted readings in order to receive reimbursement if you're in a fee-for-service model for remote monitoring. And I know that in a number of use cases, that's difficult to achieve, and has made companies and providers a little more hesitant to implement a remote monitoring program. So that's something that I hope we will see changing as our policymakers sort of recognize the different use cases and also the benefits of remote monitoring.
Yeah, that's a great point, Carrie. And we're focused on a number of pilots in this space. So I think from these pilot programs that we have around diabetes, as I mentioned before, cardiology applications, et cetera, I think we're going to learn a lot. And I think those key learnings coming out of those pilots will allow us to determine what's the right approach from a reimbursement standpoint. It may help us to identify some limitations that are come about as a result of certain regulations and try to influence policymakers around those issues. But we think there's tremendous promise here and really are excited about the opportunity to work with a number of providers to pilot these.
Yeah, the pilots that I'm hearing of are really amazing, and hopefully that's going to push us forward and making some progress.
Yes.
Marion, did you have any policies that sort of hindered you during the pandemic or prior to?
Well, prior to, sure. I remember being a provider and understanding the importance of supporting the rural community hospitals who may not have specialists. I was a surgical subspecialist in my previous life. And if you didn't have multi-payer approach to it, it was just almost impossible to set up a program. Mm-hmm. So I think, again, rolling back regulations from CMS allows things to just move forward. And then when I was at CMS, I learned, there's logistical things you have to work on, like how do you collect the copay? So those are the things that, let us innovate in that area. That stuff can be solved, but let us innovate and don't regulate us in terms of those types of things.
Yeah, the copayment is one that I'm hearing a lot about as being an impediment for patients to use some interventions, for example, like remote monitoring or other chronic care management services. That can be a bit of a barrier. So let's turn a little bit to reimbursement policies, specifically around value-based care. What are some examples of policies that you have seen that have really facilitated the shift towards value-based care?
So I was able to spend time at the Innovation Center when I was working at CMS and was very interested in episodes of care as a former surgeon. And making sure that we're thinking about multi-payer approach is just really important. And was really interested in seeing how we could make the models more simple. One of the things as we were setting up and designing models were, and again, I'm a surgeon, so forgive me, complex quality gates that people had to go through and the reporting and the regulation related to quality, which is hugely important, but just making sure we're harmonizing outcome measures and harmonizing how we're thinking about these was really important to me. Otherwise, standing up some of these models was going to be too complex for people. It just is hard to think about how you're going to set up one model for CMS and another one for another payer, and then they have their quality metrics and outcomes. So again, the simplicity of it and the multi-payer approach, to me, is what's going to move value-based arrangements forward.
Yeah. Greg, I suspect you'd probably agree on that.
I definitely agree on that. I think that is certainly a challenge. The variation that can exist is certainly challenging. And so we, whenever there's an opportunity to focus on harmonization, it's really helpful. And as we get more insight around some of the CMS models, that really is making it better, I think, for all of us. And to the extent that for payers, for our commercial business, that we can somehow emulate certain elements of that, it makes it easier for providers to really treat all of their patients in a similar fashion. They don't have to worry about, how do I deal with the program for this payer and CMS program and another payer's program, et cetera. So that's critical.
Yeah, I suspect that would have to be maddening for physicians, right?
You can't do it.
Yeah.
You can't do it.
Right.
And I've never been in a health system that didn't say you have to treat everyone equitably the same, and we defaulted to CMS. And so you just have to understand that. And therefore, again, the harmonization it's a word I overuse, but that's how much I passionately believe you have to make things the same and help providers.
Yeah, no, absolutely. Okay, so what has held us back from making the shift to value-based care? Obviously, having to segment out different types of value-based arrangements is one thing that may have held us back. But are there other things that you see that are still sort of constraining us with the shift to value-based reimbursement? Marion?
Well, I'll start and look forward to Greg's comments. I had an aha moment, and as a provider, I knew for 10, 15 years that we were on our way to assuming upside and downside risk. Upside risk isn't a thing, but upside reward and downside risk. But we were never making the movement. And when people spoke to me as a leader, clinical leader in a healthcare system, multiple ones, about assuming risk, it made me mad because I didn't have data to do iterative learning. You're asking me to assume risk, and I don't have any way of knowing how I'm doing. And at CMS at the time, and I don't mean this as a pejorative, it was going on everywhere, it would be up to 18 months before we would then true up in terms of quality incentive bonuses. And you'd know how you did in a model. And so the answer to your question is, it feels to providers like gambling unless we're sharing data weekly, if not daily, with them. Actionable member-level data so that they can iteratively learn and know they're going to meet their quality metrics, their per member per month spend, their use of specialists, track with us how they're doing things. So the ability to share dashboards, analytics, actionable data is a huge reason why we've not moved forward in value-based care. And now that there's such innovation in that area, amazing companies out there, amazing platforms, I think we're going to see a real push forward. But for me, it's been frustrating, even in my company. I know there's skeptics. They're like, Marion, we've been doing this for 10 years. Why aren't we making movements forward? I think that's a big part of it. There are other reasons, and I look forward to Greg's answer. But I would put forward the ability to share data with our provider and partners is huge, because they've got to be able to win. And in order to win, you have to have data.
And I think actionable is the key word there as well, actionable data. Greg?
I mean, I couldn't agree more. I should just say amen to that. But, I think that the sharing of data is critical. It needs to be bidirectional data.
Right.
I think that attribution, so when you're dealing with the broader healthcare ecosystem and you have patients interacting with their primary care physician, with their specialists, with others, to whom do you attribute the improvement, the savings that's realized, or if there's a deterioration, the deterioration. So that's something that I still think needs to be worked out. And there is a lot of different approaches in terms of how you do that. But I think that sharing of data is so critical. And we are fortunate that we have some partners that we work with in our community that are really focused on that, where they're taking on full risk, but we share a lot of claim information with them so that they understand what care is being provided outside of their providers, whether it's specialists or hospitals, et cetera. That's critical. And we are also getting information back that allow us to really understand what are the initiatives and programs that are really having an impact and really resulting in a change. We also have a subsidiary of ours that is in the population health business, and they really have a whole suite of services that they offer principally to primary care physicians and to specialists that is really focused on identifying improvement targets and thresholds and then sharing data on a regular basis. And we have some of our folks are going into the physicians' offices to kind of walk through performance at least on a monthly basis to talk about what's happening, what particular patient populations need maybe more attention than others. And so it's something that's certainly been very successful for us, and we think there's broader application going forward.
Yeah, you mentioned monthly meetings. I can imagine that the consistency of going in and walking through this data and saying, here's what we're seeing as compared to last month and last year, and here's what we need, we should see going forward. I think having that sort of consistent evaluation of the data is probably key.
It is.
Yeah. Anything to add?
No.
Okay. So let's take a quick question from the audience. There's one here that talks about concerns about Medicaid reimbursement policy, particularly with respect to telehealth and RPM, and Medicaid reimbursement not moving quickly enough to prevent the care gaps from widening further. Do you all have any thoughts or comments on that? Any thoughts on how to advocate for better reimbursement policy at the state level?
I think it is a great question. It certainly is something that we have observed, that certainly some of the advances we're seeing are going faster in the Medicare space, Medicare Advantage for us, and also certainly in Medicare fee-for-service, some of the CMS models that were referenced earlier, and then certainly in the commercial space. I think in Medicaid there is there's an opportunity to really catch up and accelerate the progress. But again, I think one of the challenges that you get back to is this access issue, particularly around telemedicine, that, again, some of the communities where we have concentrations of Medicaid beneficiaries are really areas that struggle a bit with broadband access, et cetera. And I think there's probably more work to be done to really provide the incentives and to provide the education that's necessary to get those populations to be more comfortable with interacting in this way. But I think we can certainly get there, but it will take a concerted effort and certainly some work with the various states on some of the underlying regulation.
Yeah, the individual who posed this question is from an FQHC, and as you all probably know, things like remote patient monitoring actually don't get separate reimbursement in FQHCs. And of course, the Medicaid, there tends to be a heavy Medicaid population with FQHCs as well. So some things that would seem to be simple fixes, right, to make that happen, still need to make their way through the system.
Agreed.
Mary, did you?
It was just hard at CMS because of the state emphasis on Medicaid to make those innovations for it. It just was. So it truly is at the state level.
Yeah, you've got 50 different landscapes to navigate. Exactly. So another audience member would like to hear from both of you on how you are working to advance value and access in behavioral health care in particular.
Great question. We have a number of value-based arrangements. One that I'm especially proud of is one that we have with an inpatient behavioral health provider that deals with substance use and other behavioral conditions. And we have an arrangement with them where we pay them a kind of a premium to the normal reimbursement rate, but in exchange for that, we have a 90-day readmission guarantee.
Okay.
So, people that come in for a residential treatment plan, let's say that's 30 days in duration, we have an expectation that that provider will make sure that once that 30-day period has expired, that the person is connected to the right resources in the community that allow them to continue with their recovery in an effective way. And if that doesn't happen and the person has a relapse and needs to come back to that facility within a 90-day period, it's considered part of that initial episode. And we have found that the level of readmission rates for this facility is head and shoulders better than any other facility in our network. And so we think that certainly there's a place for value-based arrangements in behavioral health. And I think this is just the tip of the iceberg. So I think
that's
more
fantastic. I've not heard of that model before. I think that makes a ton of sense, particularly with weaving behavioral health in. Yeah, Marion?
You know, we have been so distressed by our lack of ability to move the needle at Cambia in terms of behavioral health access and outcomes that we've made it a huge corporate objective. And we're looking for innovative partners. And as an example of one we're considering, there are certain conditions such as eating disorders that have been institutionalized and medicalized. And so thinking about ways to, in a value-based arrangement, keep those members at home and build a care team around them at home so they stay in their lives. You know, these are innovative solutions that will help us. Not only will that help us with each member, but we've got to think differently about access too. So we're really, and the reason I say that is, I think it's just important that you all understand we're never going to have enough behavioral health clinicians or providers. When you look at the pipeline, it was already severely diminished. And in parts of the country like mine in the Pacific Northwest, the need and the number of providers is disproportionately one of the lowest in the country. And so there's not an easy fix. In my career, we will not fix this. So thinking about ways of reasonably looking at what the outcome should be, reasonably thinking about how to keep the member in the home, reasonably thinking about how, and this is beyond value-based arrangements, how can we build teams around the member that might not be traditional clinicians? I think that's the only way out of this dilemma. You know, to have members just suffer, is terrible. So value-based arrangements will be important. We're being pushed by states. They're passing legislation saying that we must offer, as a payer, next day appointments for our members who are in crisis. You know, this is stuff that's really going to move the needle. But at the end of it, I think it will have to be a value-based arrangement, some sort of reasonable outcome, because then we'll keep our members in good shape. But it is, my point of this sort of meandering response is that at Cambia, we realize we have to learn more and do better because the behavioral health arena needs new innovation, new solutions.
Yeah.
Carrie, can I just build on that point? I think the point about having partnerships, I think, is critical. And one that has worked really well for us is with an academic medical center in our region that happens to have a good sized group of employed primary care physicians, but they also have behavioral health providers within their system. And in a pilot program that we did together with them, we learned that when you have primary care and behavioral health providers co-located in an office, and where the primary care physician can screen for depression, anxiety, other conditions, et cetera, and get them to the right person to start to treat those conditions. When individuals that have other chronic physical health conditions, they see tremendous improvement. And so we saw, 50% of those who were screened for depression and anxiety and got directed to the appropriate provider saw a reduction within about 6 months. And then also for those who were had high blood pressure, we saw about 2/3 of those get their blood pressure under control, and similar kind of results for diabetics with their A1C levels. So I think there's tremendous promise in terms of integrating physical and behavioral health. And I think to the extent that we can address behavioral health conditions, we will improve chronic physical health conditions for those who suffer with those as well.
Yeah, it feels like after a long time of being largely ignored, behavioral health finally has a seat at the table.
Yes. Yeah. And I think it's a place, Carrie, as well, just one last point, where technology can help. And we recently started working with a company called Quartet Health that provides some technology tools that help to get patients connected with the right behavioral health provider. And they work together with primary care physicians where that's appropriate, or they can work with care management teams at payers to help get members or patients directed to the right behavioral health providers. And it's not going to solve the shortage that was referenced earlier, but that connecting the dots faster, I think, is critically important.
Yeah, it's helpful, and we're seeing innovations in maybe non-synchronous, non-live digital behavioral health interventions that are also helpful. There's nothing obviously like having the opportunity to interact with a behavioral health specialist. However, given the access issues, some of those technology innovations can be really helpful in the room.
Agreed.
Okay, so I want to take a moment to ask each of you, in your ideal world, what should reimbursement policy look like in the foreseeable future?
Well, I would just simply say that it, it should be really arranged in a way that allows for the greatest access to care and the best outcomes in terms of the quality, both from a medical standpoint, but also from a patient experience standpoint. I think that's critically important. And I think consumers are becoming much more savvy around issues of, certainly their experience, certainly differences in outcomes that are observed among different providers, but also the cost implications as well. And I think having reimbursement arrangements that provide the appropriate incentives for providers to deliver the care whenever and wherever the patient needs it is critically important. And also that it enables us from the payer side to provide a cost equation to employers and to consumers that allows for the care to continue to be affordable. And so that is really what we're focused on, is striking that right balance. And that's going to ebb and flow over time, but that really is the intent.
Yeah, so the alignment of incentives.
Yes.
Yeah, absolutely.
Violently agree. I tie in the tremendous burnout that we're seeing, not only from the pandemic, but it existed pre-pandemic, to this fee-for-service world where it was moral injury for me personally to practice. That's how I went into medicine. So I'm a huge advocate for value-based care. Set guardrails. You're held responsible provider for total cost of care and these quality metrics. You figure out how you're going to deliver care. We're a provider. We don't deliver care. And we've sort of had to enter that space because there's maybe a lack of trust in addition to alignment. So for me, listen, we have to bring down costs. We have to improve access. Let you all, provider system, innovate, but in a way that you're responsible for cost, you're responsible for outcomes, and we are sharing data with you so that you understand how this is going to work and what you're going to be responsible for. And then we'll harmonize with federal programs, federal mandatory models from CMS.
Right.
I think that's the virtuous cycle that I see that gets providers and back in the joy of practicing medicine, provides care management for the member/patient. So I'm a huge proponent of that because I simply see no other way forward. I just don't. So I'm really optimistic because of those alignment and incentives going forward.
And you mentioned mandatory models. Do you feel like we need the mandatory aspect to, the carrot and the stick? Do you feel like,
I do.
Yeah.
I do. I think that's what's pushing us forward, and we're sort of all waiting to I think people are. It's terrible. I always mix my metaphors, but 1 foot on the dock, 1 foot in the canoe. You all heard it, but I think it'll get us all in the canoe. And so I think that is important. And I keep vocally encouraging the Innovation Center to move forward with mandatory models.
Yeah. Yeah. So our time is winding down. We have a number of really interesting questions that have come from the audience, including around coverage for precision genomics as a way of moving the needle on care, including about the impact of the proposed remote therapeutic monitoring codes and whether they're going to create a new category of digital health. And then also talking about how preventive care is treated and reimbursed. I would urge those of you who had questions in the audience that we did not get to address to come up to us afterwards and discuss. We're gonna step off and remove our microphones, but we will come right back out here and happy to talk with you about any other questions that you have. Thank you both so much for participating in this panel. It's a wonderful discussion and look forward to seeing you around the conference.
Great, thank you.